the dark.
Okay. I think Lisa Leonard is not coming tonight.
Okay.
She was supposed to tell you that last week.
All right. Well, that's all right. I'll just close the door. It'll be all right.
All right.
I'll shut off the microphone so you can't hear whoever walks through here.
Okay, thanks.
Have a nice night and have a happy Thanksgiving.
You too.
Oh yeah, I keep forgetting next Thursday's Thanksgiving.
It's hard to believe.
We'll have 2 weeks to do our homework, or are we gonna have 2 weeks worth of homework?
No, you'll have 2 weeks.
That's great.
Good evening.
Good evening. So do I have Darla and Barbara and Lisa?
You got Darla. Yep.
Did I see Barbara on there? I think we start with 15 tonight for answers, correct?
Believe so.
And 40.
Yep.
Hello, Doreen.
Hi, Lisa.
Yep, 349. Nervous when you call on me. Some of my answers are so scattered. Just like,
Hi, Angel.
Hey.
My mom's reading my resume for me before I send it to you. I just wanted to put it all down there, I think. Okay. Did you Brunswick that you worked with? Oakland? My whole family just. I used to go to, I can't remember what it was, right next to 7-Eleven. I used to go. Harry. Cooler. Really nice. August?
Doreen.
Yes.
I was really sick this past week, and I did what I could do, but I didn't get it all done.
That's fine. I'll give you the answers and you can write them on a separate piece of paper. So if you want to finish them and then check your work afterwards, you can do that, or you can
Yeah. I did some, but just not all.
Okay, that's fine.
A lot of the things that I think I got wrong on the test, it was just reading the questions afterwards, some from what I was going over. Oh my gosh.
You wonder how you did that, right?
Mm-hmm. All the time. I just don't, I get going and going and going. Yeah, it's embarrassing. Well, do we have any other games for the coding class like we did for the medical term? There's not that wheel.
There's not that many games or any games for coding like there was.
That's okay, I don't think that used to be.
Okay, let's go ahead and get started. Welcome to week 6. We're going to go over last week's answers for the Ford book. So we're going to start on chapter 15 in your study guide, page 349. And number 1, 2 kinds of statutes under workers' compensation. We have federal compensation and state compensation. Number 2, the answer would be accident. 3, occupational illness, industrial or workers' compensation illness. 4, Workmen's Compensation Law of the District of Columbia, Federal Coal Mine Health and Safety Act, Federal Employees Compensation Act, and Longshoremen's and Harbor Workers Compensation Act. Number 5, compulsory laws. Number 6, elective laws. Number 7, A is monoplastic state or provincial fund. B, qualification of employers as self-insurers. C, territorial fund. D, competitive state fund. And E, private insurance companies. 8, employers. 9, you would look for table 15.1 in your handbook, so your answers might vary on that particular one. And whatever answer you put there would be fine. Number 10 would be subsequent or second injury fund. Number 11, A, domestic or casual employees. B, laborers. C, babysitters. D, charity workers. E, gardeners. And F, newspaper vendors or distributors. Number 12, you would look at table 15-2 in your handbook for the answer there, and again, your answers may vary. Number 13, you would look at table 15.3 in your handbook, and again, your answers may vary. Number 14, the 5 types of workers' compensation benefit: medical treatment, temporary disability indemnity, permanent disability indemnity, death benefits, and rehabilitation benefits. 15, medical doctor, osteopath, dentist, or chiropractor. There are 3 types of workers' compensation claims, and what is the difference among them? The first one is a non-disability claim, where the person is injured or ill, and they're treated and then go back to work. There's no actual disability from their job. The second one would be a temporary disability claim, where the person is injured or ill and they cannot work at their job and they're usually off of work for a period of time. And then the third one is a permanent disability claim where the person is injured or ill and they cannot work and the problem usually results in permanent injury or disability. 17, the answer is percentage of the employee's earnings at a time of the injury or illness. 18, work hardening. 19, the state's Industrial Accident Commission or Workers' Compensation Board. 20, yes. And the answer to the second part of that is Workers' Compensation Appeals Board or Industrial Accident Commission. 21, the insurance carrier. 22, a third party is responsible for the injury, meaning the person is injured by an outside party. And 23, the first part is employer's report of occupational injury or illness, and the second, medical service order. 24 would be A. 25 would be B. 26, D. 27, C. And 28, D, all of the above.
Could you say 23 again?
Yes, 23 was employer's report of occupational injury or illness and medical service order.
Thank you.
You're welcome. 29 is true. 30 and 31 are false. 32, 33, and 34 are all true.
Ooh.
Do I need to repeat any of those for any of you? Let's move on to chapter 16. Page 375. All right. Number 1 is disability income insurance. Number 2 is double indemnity. 3 is residual or partial. 4, waiver of premium. 5 is yes, because he has not made any contributions toward the premium. 6 would be Social Security insurance and supplemental security income. 7, physician treating the patient. Consultative examiner. And then full or part-time medical or psychological consultant. What was that last part? Full or part-time medical or psychological consultant. Number 8 is not applicable, and that is because the injury occurred after discharge from the military. The injury is considered not connected. Thus, no veteran benefits are received for the injury. All right. First one is California, Hawaii, New Jersey, New York, Puerto Rico, and Rhode Island. On number 10 and number 11, your answers will vary because you would refer to table 16.1 in the handbook. And it should be in your textbook, correct?
Finding great problem? Yeah.
Number 12, after a claim begins, when do basic state disability benefits become payable if the patient is confined to his or her home? And that would be after the 7th day of disability. If the patient is hospitalized, the disability benefits do not begin on the 8th day of disability in all states where state disability benefits exist, even when the patient is hospitalized.
Can you repeat that last part?
Yes. If the patient is hospitalized, disability benefits do not begin on the 8th day of disability in all states where state disability benefits exist, even when the patient is hospitalized. So if the patient is hospitalized, they will be receiving disability benefits. It doesn't start on any particular day.
Thank you.
You're welcome. 13, the answer is yes, if 15 days have elapsed. On number 14, the answer is yes, because benefits become payable after the 7th day of disability. Again, this also may depend on whether the injury is declared work-related or whether the rate of workers' comp is less than the state disability benefits. 15, the answer is yes. 16, we have 4 states that allow maternity benefits: California, New Jersey, Hawaii, and Rhode Island. Number 17, the answer would be no. Betty herself must be ill or injured to collect benefits. 18, the answer is no. He must be ill more than 1 week to collect state disability benefits. Number 19, no. She will only receive benefits if disabled more than 7 days. 20, yes. As long as he has met the quarterly amount that is required to be put into the fund in the state, he is eligible. Number 21, because at the time he gets the flu, he can go on state disability, since he is not able to go for a job interview. Number 22.
Oh, Doreen, could you tell me 21 again?
Yes. First part is yes. Second part is because at the time he gets the flu, he can go on state disability since he's not able to go for a job interview.
Thank you.
You're welcome. 22 is yes, because he might have become ill whether the strike was on or not. Also, yes, to the second part, like temporary disability benefits again, yes. Why? Because more than 15 days had elapsed between his return to work at the recurrence of the illness. A person is still employed even if he or she is on strike and walking the picket line. If a person is injured on the line, it is workers' compensation, not disability. And if a person becomes ill either at home or on the line, it is disability. I will repeat that, the last part. Because more than 15 days had elapsed between his return to work at the recurrence of the illness, a person is still employed even if he or she is on strike and walking the picket line. If a person is injured on the line, It is workers' compensation, not disability. If a person becomes ill, either at home or on the line, it is disability. That's why you have that short-term and long-term disability. Number 23 is no. Why? Because he is retired and has no state disability insurance. That's the drawback to being self-employed. Number 4, again, your answers will vary here because you have to look at table 16.1 in your textbook within that chapter. Number 25, Dr. K examines Ben Yates and completes a disability income claim form because of a prolonged illness. The first answer would be employer's records. The second would be employees' wage statements and or tax forms. And the third, medical records of the attending physician. Number 26, it must be no more than 1 year old. Number 27, the two methods. Physician may bill Veterans Affairs outpatient clinic. And the second one, patient may pay physician and get reimbursed by the VA by following the instructions on the VA outpatient clinic card. 28 is A. 29 is C. 30 is D. 31 is A. 32 is B. 33 is false. 34 is true. 35 is false. 36 is false. And 37 is true. All right, let's move on to chapter 17, page 414.
We didn't do that one.
I'm sorry?
I thought it was 449, not chapter 7.
No, chapter 17. 449 is the next chapter.
I didn't have this one written down. I'm sorry.
Okay. That's all right. We're going to start with 414.
I cannot believe that. I did not do that.
Just write the answers down on a separate piece of paper and then you can go over it yourself and check your answers.
That's what I'm going to do.
That way you don't have to listen to the lecture again. My voice can get annoying.
No.
All right. Number 1. No. And the comment for this would be because no breach of confidentiality has occurred. However, the insurance billing specialist or coding clerk must never reveal to anyone anything appearing on the insurance claim without the patient's signed permission. So we're reviewing a computer-generated insurance claim before it's sent to the insurance carrier, and you notice the patient's name as being that of an old friend. You quickly read the code for the diagnosis. Is this a breach of confidentiality? Because you are the billing specialist and coder on this particular issue. Yes, the name, triggers a response, but you're doing your job and making sure that you're getting the claim out the door nice and clean that first time. So there's no breach there. But just keep in mind not to reveal anything to anyone. Number 2, the answer would be yes. With no signed authorization, no information may be released. Number 3, the 3 instances of breaching confidentiality in a hospital setting. The answers may vary here, so just something along the lines, you might have any one of these responses. All you really needed was 3 of them. So I can tell you what they are, and you can see what you got for answers. The first one would be discussing patient information with coworkers or other hospital employees. The second one, talking about patient's information with a spouse or children. The third one, giving copies of a patient's medical reports to family members. Relaying confidential information via cellular telephone. And then using samples of typed insurance claims with identifying data on the documents in your job-seeking portfolio. So you really only needed to have 3 of those, and anything, close to those answers is what I'm looking for. Okay, number 4. What is the purpose of appropriateness evaluation protocols, also known as AEPs? These criteria are used by the review agency for admission screening. The Medicare Prospective Payment System, also known as PPS, requires that all patients meet at least 1 severity of illness or 1 intensity of service to be certified for reimbursement. So let's talk about what that means. And it plays right into an article that I'm reviewing for accuracy for a publication right now. Not only does Medicare require it, but all of your payers require it, where when a patient comes in for a service, we are determining medical necessity, whether that is in evaluation and management, in a primary care office, ear, nose, and throat, OBGYN, or chiropractic office. You need to show medical necessity. So this is where that documentation is very important, why the patient presented. And when we get into the Buck book, we will actually be going over scenario for evaluation and management and the scripting that might be involved when we're looking at documentation. But that's the big thing, documentation, 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 because if it wasn't written down, it never happened. So you telling me in passing that something happened, if I go in later on and look at the notes and see that that note is not in the electronic health record, as far as I'm concerned, that never happened. Okay? All right, number 5. If a patient under a managed care plan goes to a hospital that is under contract with the plan for non-emergency admission, what is necessary for an inpatient admission? What did you have for that, Emily?
I had, they must be referred by a primary care physician and obtain preliminary authorization for the length of the hospital stay.
Yes, they must be referred by their primary physician and obtain a preliminary authorization for the length of that hospital stay. So that was something that happened today for a work comp case that I was working on. The work comp doctor authorized or wrote 10 visits, but the actual insurance company only authorized 5. So I had to call the adjuster who was handling the case and just clarify, do we have 5 visits or do we have 10? how do you want me to handle this? Because obviously you want to make sure everything is on an even keel with everyone involved. So the adjuster said, we were under the understanding that the doctor referring was only asking for 5 visits. I said, well, I'm sorry, I have 10 here on this request. She says, well, I've approved 5. At the 5th visit, if you feel he needs more visits, please just give me a call and we'll authorize more visits. And what that also means, which she didn't say, is that they'll be requesting notes to determine their ill necessity. So I made sure I let the physician know that today. So come the 5th visit, we're going to be providing documentation to support that. Number 6, when a patient receives diagnostic tests and hospital outpatient services before admission to the hospital, and these charges are combined with inpatient services, becoming part of the diagnostic-related group payment, this regulation in hospital billing is known as the 3-day payment window or 72-hour rule. Number 7, the answer is principal. Number 8, we have several answers here. Rule out, suspected, likely, questionable, possible, and still to be ruled out. All right, from number 9, I didn't expect you to do any of those because they are codes. Number 10, the diagnosis of coronary atherosclerosis is subject to review by the review agency. If a patient is admitted for consultation only, the entire payment for hospital admission, as well as any physician's fee involved, will be denied.
Could you repeat that last part?
Yes. If a patient is admitted for consultation only, the entire payment for hospital admission, as well as any physician's fees involved, will be denied.
Okay, thank you.
Yes. So, what happened here is that the patient should actually just have been diagnosed. Should have just been admitted instead of going in for a consultation. The consultation usually will be in the practitioner's office, and from there they would determine admission, where they would perform more diagnostic testing to confirm the diagnosis of coronary atherosclerosis. So the physician, and this is as an auditor, I would look at this and say, all right, well, Dr. Dalton, he is suspecting that Mrs. Benson has this. So he's going to admit her for some testing. It shouldn't be that it was a consult, and that's how they get you here, is that the patient should have been admitted, not consulted. So the admission would be paid, the consultation wouldn't. All right, name 5 payment types under the managed care contracts. So your answers are going to vary, and you may have any 5 of the following ones that I will list below. And if I go too fast, just say something and I'll slow down. The first one might be ambulatory payment classifications. Bed leasing, another. Capitation or percentage of revenue. Case rate. Contract rate. Diagnosis-related groups. differential by day in hospital, differential by service type, fee for service, fee schedule. So for example, fee maximum schedule, fee allowance schedule, workers' compensation fee schedule. There might also be a flat rate, a per diem, a percentage of accrued charges, periodic interim payments and cash advances, RVS, also known as relative value studies or relative value scale, RBRVS, resource-based relative value scale, UCR, usual, customary, and reasonable, withholds, managed care stop-loss outliers, case-based stop-loss, reinsurance stop-loss, percentage stop-loss, Medicare stop-loss, charges, discounts in the form of sliding scale, sliding scales for discounts and per diem. And we really only had to have 5 of those. Okay? But those are some of the payment types that you will see under managed care contracts. All right, number 12. Baby Stevens falls from a high chair, cutting his head. His mother rushes him to St. Joseph's Medical Center for emergency care. The physician examines the baby, uses 2 stitches to close the laceration, sends the child for skull radiographs, and then discharges him home. Will the emergency care be billed as inpatient or outpatient? What do you think, Angel?
Outpatient, because he went home after, he didn't stay at the hospital.
Right. Outpatient. Number 13, name 7 variables that affect Medicare reimbursement under the DRG system. First one would be the patient's principal diagnosis. The second one, the patient's secondary diagnosis. C, surgical procedures. D, comorbidity and complications. E would be age and sex. F would be discharge status. And then G would be trim points, number of hospital days for a specific diagnosis. Number 14. Those we're talking, 14 is talking about the UBO4, which is a claim form that hospitals use. 14A would be 011X. 14B would be 013X. 14C would be 42, 43, 44, and 45. The field locators on the UBO4 claim form, the field 42 is the revenue code that determines per diem, case rate, flat rate, CPT code, and so on that applies per the contract. Again, we're talking about hospital billing here, okay? The contracts are huge.
So should this be going over my head? Or
Yes.
should I? Okay.
Yeah.
I'm making sure. I
If
should
it
be
goes over
understanding
your
it.
head right now, it's absolutely okay.
I'm just making
Alright.
sure I'm not.
No.
Yeah, I didn't understand that.
Yeah. No. Field locator 43 states the descriptive category of the service rendered. So the UB04 form is just a little different than the CMS 1500 form. And that's basically what these fields are telling you. Field locator 44 shows the room rates and the HCPC and the CPT code numbers. Field locator 46 shows the number of times and units a single procedure or service was performed. So here they're talking about field locators. On the CMS 1500 form, they're talking about, box 24J or 24G, all right? And field locator 47 is the total charges by department revenue code, the total for this bill, and the purpose of this field is to collect the statistics for comparisons or set limits for reimbursement. Over on the mix and match, all right, mix and match. The first one you should have is letter F. N is the second one. K is the third one. I, next to withhold. O for charges. J for ambulatory payment classifications. I for case rate. G for diagnosis-related groups. H for differential by service type. C, periodic interim payments. M for bed leasing. A for differential by day in hospital. B, capitation. E, per diem. And D, percentage of revenue.
Could you say case rate again?
Case rate is I.
Aye.
So there's two I's.
There was two I's, withhold and case rate.
Oh, withhold, sorry, L.
L.
Sorry, withhold is L. I apologize. It's late at night. All right, number 17, you should have B. 18 is C. 19 is D. And 20 is C. 21 is true. 22 is true. And 23 is true. All right, did I give you root operation review? Did any of you do that one?
I tried and
No.
All right, well, because it's ICD-10 PCS, I'm not worried about you doing that one. I wouldn't even try it, so don't worry about it. Let's get through ICD-9 first. How's that?
thank you.
All right, let's turn to page 449. All right. Starting with number 1. You should have placement personnel, classmates, instructors, and school counselors. Some of the skills that may be listed on your application form or in your resume would be procedural coding, diagnostic coding, knowledge of insurance programs, completing or transmission of the CMS 1500 insurance claim form, typing or keying a specific number of words per minute, and optional would be a second language. So if you have the skill, knowledge of terminology and knowledge of use of computer software, that's good too. You might even say knowledge of Microsoft Office. Number 3, there's 2 ways to handle the question about salary. You can write negotiable or flexible, or to discuss the topic during the interview. Those are quite valid. Number 4 would be to get the employer to schedule an appointment for an interview. Number 5, some of the items that you might have in your portfolio.
Doreen, could you say number 4 again, please?
Yes, number 4 is to get the employer to schedule an appointment for an interview. And then some of the items, number 5, that might be in your portfolio would be letters of recommendation, school diplomas or degrees, transcripts, certificates, names and addresses of persons providing references, copies of resume, time typing tests certified by the instructor, samples of typed insurance claim forms with evidence of coding skills, and other items related to education and work experience. All right, so you're being interviewed for a job and an interviewer asks this question: what is your religious preference and how would you respond? How would you respond to that one, Darla?
Can I tell them it's none of the business? No, I'm kidding.
I'm sure you can do it in a more tactful way. You could say, I don't believe that's relevant to this interview.
Yes.
You can also refuse to just answer it based on personal preference.
Can I refuse to answer it based on my religious preference?
I'm sorry?
I said, can I refuse to answer that on the basis of my religious preference?
You can refuse to answer.
I have a question about that.
Yeah.
So if you do that, even if you do it in the most polite way, would they take that as kind of standoffish?
No.
It wouldn't count against you.
I just wouldn't say that's none of your business, or
Right.
I don't
I'm
want
saying even if you say it respectfully,
No.
not the problem. They
no,
can't.
it's not a
Because
problem.
they can't.
I can't legally. It's an illegal question, and it may be ignored or not answered at all. If a short period of time elapses after an interview and the applicant has received no word from the prospective employer, what follow-up steps may be taken? What do you think, Angel?
Write a follow-up letter or send an email and indicate a thank you for interview and restate interest in the position.
Yes, place a phone call as well. You could try that.
Okay.
Number 8, if an individual creates a billing company and coding services are to be part of the offerings, the coding professional should have what type of professional status? Lisa, what do you think?
AAPC or the AHIMA.
Right, they should be certified by one of those. U. Beeson was the owner of XYZ Medical Reimbursement Service. A fire occurred, damaging some of the equipment and part of the office premises and requiring him to stop his work for a month so that repairs could be made. What type or types of insurance would be helpful for this kind of problem? Usually business interruption insurance and property insurance. Number 10, Gwendolyn Stevens has an insurance billing company and is attending a professional meeting where she has given business cards to a few attendees. Give 2 reasons for using this business marketing strategy. It would be so you can advertise availability and services, and it helps with networking. Number 11, what is the difference between certification and registration? Certification is a statement issued by a board or association verifying that a person has met professional standards. Registration is an entry in an official registry or a document that lists names of persons in an occupation who satisfy specific requirements or attain a certain level of education and pay a registration fee. So registration, again, is an entry in an official registry or document that lists names of persons in an occupation who satisfy specific requirements or attain a certain level of education and pay a registration fee. Number 12, what are some ways an insurance billing specialist may seek to keep knowledge current? Become a member of the professional organization. B, find a mentor for advice, criticism, wisdom, and guidance. C, network with members of a professional organization as well as with those working in the field. And D, if not a member, subscribe to newsletters and journals published by professional organizations. The answer is Medicare recipients. 14, number of hours worked, quantity of work done each day, and corrections applied to her work by officials in the contracting hospital.
Can you repeat those 3 words?
Yes. The first one, again, is number of hours worked, quantity of work done each day, and corrections applied to her work by officials in the contracting hospital. Give the names of at least 2 national organizations that certify billers and coders. I will give you a listing of several. You could have had any of those 2. Alliance of Claims Assistant Professionals, American Academy of Professional Coders, American Association of Healthcare Administrative Management, American Association of Medical Billers, American Health Information Management Association, American Medical Billing Association, Medical Association of Billers, Medical Management Institute, National Association of Medical Billers, National Center for Competency Testing, National Electronic Billers Alliance, and Professional Association of Healthcare Coding Specialists. As you can see, there's a lot of billers networking out there. Multiple choice. 16 would be D. 17, C. 18, B. 19, C. 20A. Then your true or false. 21 is true. 22 is false. 23 is true. 24 is true, and 25 is false.
That's it.
All right, any questions?
We don't have to write anything down.
So you do not need the board meet book for next week. Actually, next week is holiday.
Oh, yeah.
So we will come back here, I believe it's December 4th. Whatever that Thursday is in the 1st of December. So you will need your Buck step-by-step textbook and workbook.
We were supposed to bring that tonight, right?
Yes.
Oh.
So we will move on to the Buck book.
Hey Doreen, when should we expect the rest of the books?
I haven't heard anything back yet, and I'm hoping we'll get them over break. So Emily, you have your ICD-9 book, right?
Yeah.
All right. So
There's only two more.
you have your CPT, so you're waiting on your HIC picks.
Yeah.
Okay.
I think there's one more.
Maybe the physician review.
No.
Okay. So Angel, do you have your ICD-9 book yet?
Is that the small one with the binding on it?
It might be the small gray one that just came
Yeah,
in.
it is gray,
You
yeah.
have yours? Did you bring it tonight?
Oh,
Okay. It's just,
And I have the HIC pit.
okay.
I mean, dictionary.
So the ICD-9, I know that they were out of the spiral bound one and they were sending the gray short ones that were ICD-9. They look very similar to your HIC-PIC book as well. So did you receive that one?
Yes, that one, and I have the HIC pit.
Okay, you didn't get your CPT?
Yes.
Oh, you have all three, okay.
Trying to find it.
All right, and so Lisa, you're saying that you don't have your ICD-9 book?
No, I don't have my hip pick.
Okay, do you have your ICD-9?
Yep, I got the little compact gray one.
Yeah, I don't have exam review.
And Lisa, you have CPT?
Yes, I do. And
Right.
one extra.
Which is an extra CPT or an extra ICD-9?
CPT.
Okay. So sometime I've got to meet up with you to get that book. We need to figure that out, please.
Yeah, no problem. Just let me know.
Okay. Where do you live again?
West Gardner. Where are you? Brunswick?
Stockholm.
Oh, we're a ways away.
Yeah. So I might have to just have you mail it to me and I'll pay your postage.
No, you don't.
All right, Darla, do you have the ICD-9 book?
Yeah, I do.
And the CPT?
Yep.
Okay. So for next week then, I would like you to bring, for December 4th class, bring your Buck step-by-step, both the textbook and the workbook, and your ICD-9 book.
Doreen, the only book that I don't have is the hip pick.
Great.
Okay.
All right, let's turn to page 1 in your book. This starts chapter 1, which is all about reimbursement.
Cute picture at the top.
What?
That's a cute picture of the lady at the top of the page. That's
yeah.
encouraging.
So basically, just as that picture states at the top of the chapter on page 1, is that you will probably feel a bit lost in the beginning, but don't let that slow you down. You are learning to identify the little pieces to a big puzzle. Wait until the puzzle is completed before deciding if you like the big picture. You will be greatly rewarded. And that's exactly true. And the reason that I started the class the way I did this session without you doing anything on Evolve until this last week was because I wanted you to be able to focus on just the workbook and the textbook. Because I knew that with the billing and reimbursement part of the course, I wanted you to be able to do some more of that hands-on type of stuff that you do in the workbook that we can cover in class like we have been, giving you the examples that I gave you throughout the different chapters. So now, getting into the coding part, we really will start getting into the meat and the foundation of coding. So as I explained in the beginning, you really will be able to go out there and present yourself as a certified biller / coder, or certified coder, whichever position you want to apply for. And I would suggest that you have a resume for both, and that you just utilize them as the job opportunities present themselves. So this particular chapter is all about reimbursement, HIPAA, and compliance. And those three things are actually all in their own a very specific category: reimbursement, HIPAA, and compliance. But sadly, with reimbursement, you have to make sure that you're not how do I want to say this? That you're not breaking any HIPAA or compliance issues, because there are specific rules and regulations around reimbursement. So the third-party reimbursement issues that we might run into is that people bill fraudulently or are abusive. And we'll get into that as we move into the book. But basically, in the third-party reimbursement issues, each of your coding systems play a critical role in reimbursement. So it's actually our job to optimize payment. So what is the largest third-party payer in the U.S.? Who can tell me that?
Isn't it Medicare?
It is. It's Medicare. So over on page 2, we're still in the introduction. The entity that is the largest third-party payer in the U.S. Medicare. So, what is the coder's role? What do you believe your role is as a coder? Angel?
To make sure you're accurate with what you're coding and that it's for the proper medical procedure and it's not.
Right. Accurately code
Right.
the services and the procedures that are rendered in the office so that they're properly reimbursed. You will have ethical issues that will continually surface, and they must be handled by you as the coder. So some of the examples that we might run into would be the pressure to upcode a procedure or to restate a diagnosis to obtain better payment. Upcoding or maximizing is never appropriate. Your upcoding and your assignment of comorbidity and complications is based only on laboratory values and using the non-physician impressions or assessments without the physician agreement would be considered fraudulent. So you do not want to upcode. All right? What issues do population changes create for the healthcare industry? What do you think, Lisa?
Because there's so many of us.
Right.
The older generation is here, and it's a big one, and just the population.
Right, because as people live longer and as the baby boomers start to reach retirement, the elderly population will increase, which will then create a greater use of the healthcare services, and Medicare becomes an even greater component of the medical office's revenues. By 2050, 20% of the population will be 65 or older. Okay? The elderly is the fastest growing patient segment. So your Medicare is getting bigger all the time. The beneficiaries for Medicare increased from 19.5 million in 1967 to 38.1 million in 1996. We're talking about a 95% increase. All right? So the increasing numbers of your elderly people, the technological advances, and the improved access to health care have increased the consumer use of healthcare services. By 2018, you're looking at the national healthcare spending is expected to reach $4.4 trillion. So what does that mean for us? Believe it or not,
There's going to be nothing left.
job security.
Job security, yeah. Yep.
Job security. Okay? Because they need us to make sure it's all getting in the system right. And then what happens if we have a crash? We have to be able to figure out how to take care of it in the middle of a computer crash. Your Medicare program was established in 1965 with the passage of the Social Security Act. There are two parts, Part A and Part B. The program was dramatically increased. It increased the government's involvement in healthcare. The advantages were that more elderly and disabled people would have access for affordable health care. The disadvantage is that the government involvement brings the bureaucracy and the complicated regulations. Your Part A is the hospital insurance. Your Part B is considered the supplemental or the non-hospital. So this would be the physician services and the medical equipment. That would be Part B. Part C are your Medicare Advantage plans, the healthcare options. They were added later and they were formerly termed your Medicare Plus Choice plans, but they're now just considered Medicare Advantage plans. And your Part D are your prescription drugs. So who can name some of the other Advantage plans out there? How many of you have heard of any of them?
You mean like Medigap? Is that what you're looking for?
Well, Medigap is what we call the secondary plan, but what are some of the payers out there? What are some of the names for those plans?
Harvard
AARP.
program.
Humana?
Humana, Martin's Point, Today's Options, Sterling Benefits, Bankers Life, AARP, Aetna, Secure Horizons. Aetna would be Medicare Complete, Anthem Medicare Complete, Mail Handlers, Federal Blue. Okay, those are all types. Actually, those are all payers who offer a type of supplemental or advantage plan. Now, here's my 2 cents on the advantage plans. My concern for the elderly with the advantage plans is that they're not being given the proper or correct information, or they just don't understand what they're being told when they're being offered their plans, these plans. The advantage plans, and keep in mind, advantage versus supplemental. We're talking 2 separate things here, okay? Your advantage plans take the place of Medicare, okay? Your advantage plans take the place of Medicare. So when a patient comes into me and they say, well, I have Medicare and I have Humana, I'll say, no, you don't. You just have Humana. And then I sit there and I explain why to them. But it doesn't mean that they don't have Medicare for other things. It just means that specifically in chiropractic and maybe some other services, Humana picks up the bill. Whatever Humana doesn't cover, Medicare would then turn around and be billed. Okay?
Are these kind of like co-insurances? Like what we talked about before?
Nope, these would be co-pays.
Co-pays, okay.
We'll talk about that. So with your advantage plans, what happens is the patients have a smaller premium. It might be a monthly premium or a yearly premium. I don't know what it is, okay? What happens though is that in the long run, they have a copay per visit. And I've seen some of those copays at $40 a visit for an advantage plan, okay? So the advantage plans, again, take the place of your Medicare plan. They are not a supplemental. We'll talk about supplemental in a minute. So with the advantage plans, you're going to see more copays versus co-insurance. The copays are your fixed dollar amounts. So $20, $40, $30, always a set dollar amount. Some as low as $10. It just depends on the plan, okay? So now let's talk about your supplementals. All right, your supplementals are the ones where Medicare pays 80%. Medicare is still primary, but the supplemental kicks in and pays maybe the deductible or the co-insurance responsibility. The co-insurance responsibility for the patient would be 20%. Your supplementals follow Medicare guidelines, just like your advantage plans do. So if Medicare doesn't cover an exam in a specialist office, the supplemental or the advantage plan will not cover it. When you verify an insurance and Medicare says, we follow Medicare guidelines, that's exactly what they do. If Medicare doesn't pay it, they will not pay it, which means that the patient is responsible. Okay? So your advantage plans are a set dollar copay. Your supplemental plans, usually cover deductibles and co-insurances, maybe some therapies, but usually if Medicare doesn't cover it, this supplemental does not cover it. Your supplemental plans are going to be the AARP, the Federal Blue, the Sterling Benefits, the Bankers Life, some United Healthcare, right? Those are your supplementals. Your Advantage plans are Humana, Martin's Point, Aetna Medicare Complete, Anthem Medicare Complete, Secure Horizons, those types, okay? Any questions so far?
Kinda. What is the sense then of the supplementals? Just in case there are more procedures or so that are not covered?
Believe it or not, because the supplemental picks up the 20%, that 20% on certain services could be a huge amount for some Medicare recipients.
Okay, so the supplemental is the co-insurance then?
Yes.
Is that what I'm understanding? Okay,
Yes.
thank you.
So if you come into my office, and let's just say we have a $50 charge. You have Medicare and a supplemental. Now, Medicare does not pay for the exam, the x-rays, or the therapies. So Medicare for chiropractic adjustment, let's say they cover, let's just say $27.96 on a $50 charge. Then the patient is responsible for their 20% co-insurance, which I think it works out to be 7 something. Okay, don't quote me here because I'm trying to go on what's in my head. Then as a participating provider, we need to adjust off $12 to $14. That turns around and gets submitted to the supplemental. The supplemental will come back and pay that $7.21 or $7.16 or whatever it is I said earlier. That's the advantage. The patient doesn't have to pay that $7 a visit.
But they'd be responsible for the 17?
No, as a
No.
participating provider, we are contracted to
Gotcha.
write off any difference between the allowed amount and the charged amount.
Okay.
Okay?
Is it just about the same as doing the Plan F as a supplementary? Is that the same thing?
Plan F is your supplementals, yes.
Okay.
All right. Those people who are covered usually are 65 and over. Later on, Medicare added disabled and permanent renal disease, end stage or transplant. And then usually there are some persons that are covered such as beneficiaries. Okay? So your people who are covered under Medicare are called beneficiaries. All right, over on page 3, the officiating office for Medicare is the Department of Health and Human Services. It's also known as DHHS. It delegated to Centers for Medicare and Medicaid Services, otherwise known as CMS. CMS was formerly HCFA, the Healthcare Financing Administration. CMS runs Medicare and Medicaid. CMS delegates their daily operation to Medicare administrative contractors, also known as MACs. These acronyms are things that will be on the national exam in some form or another. We will be going over highlighting and underlining those things in your ICD-9 book next week, or next time we have class, okay? So the responsibilities of CMS are basically to operate Medicare, use the MACs and private insurance companies that handle Medicare in specific areas. All right, the funding for Medicare comes from Social Security taxes, which is usually an equal match made from the government, right? And then your MACs handle the paperwork and pay the claims. So the funds for the funds for Medicare to operate are generated from the payroll taxes that are paid by the employers and the employees. And it is the Social Security Administration that collects and handles the funds which flow through CMS to your MACs. All right, let's talk on page 6, Part B, supplementary insurance. We pretty much ran over that already, but let's just reiterate. For Part B, Medicare will pay 80% of the covered charges. Your beneficiary will be responsible for the remaining 20%. Again, when you see a percentage, it's going to be a co-insurance. The beneficiary is also responsible for the annual deductible, and that changes every year, okay? I know this past year it was $147. I don't know what it is for 2015. I haven't even looked yet. All right, let's move back to page 5 for a moment, and let's talk about your QIOs. What is a QIO, Emily?
A quality improvement organization.
A quality improvement organization. All right. So what is a non-participating QIO provider, Lisa?
The payments go directly to the patients, 5% lower fee, slower processing.
Exactly. So your participating QIO providers actually sign a QIO agreement with the MACs. They agree to accept whatever the MACs pay as payment in full. This is that box 27 on the CMS 1500 form that when you check it, you check accept assignment. And what that means is that the provider gets paid directly, not the patient. All right? Your providers, they should be licensed by their local and state health agencies to provide the services and supplies to the Medicare patients. And there's approximately 50% of the physicians in the U.S. that are participating providers. That's actually a low number, because most physicians, they don't want to deal with Medicare.
Why is that?
Because there's so much regulation around what can and can't be done for a Medicare patient. You find that a lot of providers will give services to patients and not charge them for it, or write the services off, because the regulation surrounding what a provider can do for a patient is, it's just very frustrating, because the patients need the care, and you know, you're talking about an economic community that can't really afford a lot of services. So the hard part with that is providers go above and beyond the majority of people, at least the ones I've come in contact with, they go out of their way to provide services for Medicare patients that would not elsewhere get that type of service and be receiving benefits and improving their quality of health without these providers not giving them the service. So an audit for a practitioner on Medicare patients alone could literally cause them to close their doors if they were to be audited and found to be non-compliant. And that's really sad because they're providing a good service. The patients are receiving good quality health care, and they're actually resolving health issues that otherwise might not see treatment, or the patient suffers from things that they don't necessarily, the primary care doesn't necessarily understand why, but if they go and see a specialist, they get the care that they need. And a good percentage gets it resolved and gets resolved. So most practitioners find it very hard to take on Medicare patients because of the big hearts that they have and wanting to help the people that they help.
So basically, they get their hands tied.
Their hands are tied.
Yeah.
It makes it really difficult. I can tell you some stories about patients who have come in for chiropractic care for shingles. Okay, and let's say this chiropractor also does acupuncture. Okay, acupuncture is not a covered service by most of their payers. So the patients have to pay out of pocket. All right, but guess what? Within 8 visits, this patient is not suffering from shingles anymore.
Wow.
So they didn't take any medication, and the acupuncture helped to relieve the discomfort and help their body to heal and resolve the shingles. And I know most of you are aware, for those who are elderly, shingles can be a huge deal. They suffer quite a bit. Sinuses. This is the time of year where sinuses really flare up for people. Well, a chiropractic adjustment can help patients with their sinuses. Acupuncture can help with sinuses. So we're seeing the Medicare population reaching out to more and more alternative health care, but Medicare doesn't pay for it. So, yes, the hands are tied.
It's sad. It's really sad.
It is. So, why should we be a participating provider? You know, 2 of the biggest things is basically you get paid faster. You still are only allowed to accept what they give you as an allowed amount. Your non-QIO providers will see a less speedy, or they don't get paid as fast. Your QIO providers, they get paid faster, they get a 5% higher fee schedule, and they can get direct payment right in what they call EFT, electronic funds transfer. Also, you get your name in the provider directory that gets sent to all of the beneficiaries. We talked a little bit about Part A. If you turn to page 5 and 6, Part A is the hospital. So more than 90% or more than 99% of hospital claims submitted electronically. Your hospitals who submit paper claims are on the UBO 4s or the CMS 1450 claim form. Your diagnosis codes are the basis for your payments. This is where the MSDRG or the Medicare Severity Diagnosis Related Group is used. And we will actually talk more about that in Chapter 31. What determines eligibility for Part A? Basically, your beneficiaries are automatically eligible for Part A when they become eligible for Medicare. There is a listing of services that are covered by Medicare Part A. Medicare Part A would cover the basics of a hospital stay, so a semi-private room, some meals and special diets, and only medically necessary services. They would basically look at it as a no-frill stay. So any of the personal convenience items, you know, slippers, TV, non-medically necessary items, you need to bring those from home where you pay extra. Some other covered services for Part A, you might see rehabilitation, skilled nursing, personal convenience items or long-term illness or disabilities, home health visits, hospice care, not medically covered. If it's not medically covered, it must meet certain criteria. All right, the coding systems that are used to report Part B services. Well, we just talked about them earlier. That would be your CPT codes, your HCPCS codes, and your ICD-9 codes. Page 7, let's talk about Health Insurance Portability and Accountability Act. This was established in 1996, and it's all around administrative simplification.
It's all around what?
Administrative simplification. It will also include your electronic transactions, your privacy, your security, and your NPI, which is the National Provider Identification Number. Over on page 9, the Federal Register. The Federal Register is an official publication for all of your presidential documents, rules and regulations, proposed rules, and notices. Your coders must be aware of the changes in the Federal Register that might relate to Medicare reimbursement, so that Medicare charges will be submitted correctly. Because the government is your largest third-party payer in the nation, even some of your smallest changes in the rules that govern your reimbursement can have major consequences. So, if you turn the page to 12, you'll see an example of a page from the Federal Register. Each year, there are proposed changes to the various payment systems, and you will see those published early. Usually several months pass so that interested parties can comment and make suggestions about proposed changes. You will also notice that the final rules are published in the fall editions. And when that happens, your changes are implemented the following calendar year. You will see that October contains your hospital facility changes, and November and December would contain the major outpatient facility changes and physician fee schedule changes. Over on page 11, outpatient resource-based relative value scale, otherwise known as RVRVS. This was implemented to decrease Medicare expenditures, to redistribute physician payments more equitably, and to ensure quality health care at a reasonable rate. The physician payment reform was implemented in 1992. OBRA in 1990 required that before January 1 of each year, beginning in 1992, the fee schedules that determine payment amounts for all physician and services would be established. And if you look down below at the bottom of the page, OBRA is the Omnibus Budget Reconciliation Act. Basically, what this does or did is that it paid physicians the lowest of the charge for the service, the customary charge, and the prevailing charge in their locality. So what does that mean? All of the fees, the fee schedules, are based on location, region, and economics. So Southern Maine is paid differently from Central Maine and Northern Maine, even Eastern Maine. It's just because of the economic society. Your national fee schedule replaced the RVRVS. It was actually termed Medicare Fee Schedule, or also known as MFS. As we spoke earlier, payment is 80% after the patient deductible, and this is used for physicians and suppliers. Over on page 13, wherever you see a hand that says check this out in your book, if you have time, I would suggest that you go check this out, okay? The relative value unit is the nationally unit values assigned to each CPT code. You will see that local adjustments are made to include the work and skill that's required, any overhead costs, and any malpractice costs. So basically, your unit values are determined by the amount of time, effort, and technical expertise that's required, your overhead, and cost of malpractice coverage. There was a group from Harvard University that analyzed the service. They identified its separate parts, and they assigned each part a relative value unit. These parts, or the components of the service, as we just mentioned, are the time, effort, and skill, the overhead and practice. So the work, the overhead, and the practice. That's how they come up with your RVU. So what does this mean for you as a coder? Most of your payers' fee schedules come out already figured, and all you have to do is use the fee schedule. There are programs out there that help you to determine the RVU. So it would be easy enough to plug in the work, the overhead, and the malpractice figures and come up with an RVU, but you're better off just using the RVUs that they submit and send to you, or that you can look up. You don't have to manually go in and figure out any RVUs at all. It's part of what they send you. It's part of the fee schedule. It's already figured in for us. But this is just so you know, how is an RVU comprised. So the geographic practice cost index and the conversion factor. This is where the national dollar amount that is applied to all the services according to the Medicare fee schedule and the geographic location. As I just mentioned, Northern Maine, Eastern Maine, Southern Maine, we all get paid different amounts for a particular CPT code. And it's just because Northern Maine, you have people who have lower incomes versus Central, Eastern, and Southern Maine. Annually, CMS updates the RVU based on the national and local factors. So they're looking at this nationally and locally. The beneficiary protection applies to the physician payment reform, the Omnibus Budget Reconciliation Act of 1989, and the maximum actual allowable charge, also known as the MAAC of 1991. The conversion factor, as I mentioned, this is the geographic practice cost index and the conversion factor. This is the conversion, the geographic practice cost index is the scale of the cost variance of charge locations. Again, it might change. The charge location will vary throughout the whole state. The conversion factor, you take the national dollar amount that's paid on the Medicare fee schedule, you convert the RVUs to dollars, and it's updated yearly. So again, the RVUs, the geographic cost index, the conversion factor, it's just something for you to know about so that if you ever had to try and figure out how to do it, guess what? You can Google it.
Can I ask you a question?
Sure.
You're saying, but most jobs where we would be doing billing or coding would already have this program in the system?
You wouldn't even have to use a program. You would just be using the fee schedule that's given to you by the payer. Because that fee schedule already has everything factored into it.
Okay.
So my fee, my allowed amount in Southern Maine is different than the allowed amount in Northern Maine for the same CPT code. Okay?
Yep, thank you very much.
All right, let's talk about Medicare fraud over on page 17. Fraud and abuse. This program was established by Medicare to decrease fraud and abuse. Medicare defines fraud as the intentional deception or misrepresentation that an individual knows to be false and does not believe to be true, and makes it knowing that the deception could result in some unauthorized benefit to himself or herself or to some other person. Some examples of fraud would be altering medical records, upcoding, phantom billing, and double billing for the same service. What is phantom billing, Lisa?
Billing something that never happened.
Exactly. Beneficiary signatures. Beneficiary signatures on file.
Where is that?
I don't know.
Oh, okay.
I'm gonna get up just for a moment and stretch my legs.
That's fine. Right at the top of page 18 in that first paragraph, about midway, it says something about patient's signature. After the patient has received a service, the Medicare claim is filed automatically without the patient's actual signature. But a standing approval also makes it easy for unscrupulous persons to submit charges for services never provided. Okay, so patient signature, basically, you want to make sure you have a signature on file. If you don't have a patient signature on file, that means that you really didn't receive authorization to bill those services. Most of your Medicare patients do sign a standing approval, which is from the office. So they might sign an office policy where somewhere on there it says by, signing this agreement, you accept that we will bill your services for you and accept assignment for payment and keep your signature on file, something along those lines. So basically a signature on file allows us to file the claims automatically, and what happens or can happen is that someone can fraudulently bill for services based on having those signatures on file. And as we all know, that is fraud and abuse. So anyone who submits to Medicare for services can be a violator. That would be your physicians, that would be your hospitals, your laboratories, your billing services, and even you. You must validate the services were actually provided by consulting the medical record or the physician. So what can fraud be? What forms does fraud take? Billing for services that are not provided, that can be fraud. Misrepresenting a diagnosis. I can tell you that probably 98% of the time, you're not misrepresenting a diagnosis as much as you are picking the closest diagnosis you can get. Honestly. Kickbacks. What are kickbacks? What's a kickback, Emily? Okay, a kickback is where you have a deal with another provider to refer to you. And you offer them some type of compensation. Unbundling services. What do you think unbundling services would be, Angel?
What did you say?
Unbundling services. What do you think that would be?
That's like if you have two different physicians, the doctors and the physician's office, and if you try separating them, it's supposed to all be one.
Kind of. Let's say you walk into the office and you actually have 2 or 3 procedures. And there might actually be one procedure code that combines all 3 of those procedures. So what you're supposed to do when you code is pick the most appropriate code. So when we get into the specific coding, you will see this. It's called combination coding. And it's where you might have 2 or 3 different things, but there's one code that will code those procedures. If you separate them and list them individually, that is what's considered unbundling. And what people do is they normally unbundle unaware that they're doing it. Okay? It's not really something I've seen people do intentionally. And then usually a routine waiver of co-payment. It is against the law to waive a person's co-payment. Just because I know you, Emily, I can't say, oh, nope, you don't have to pay me today. I can't do that, all right? Doesn't matter if you're family, friends, another professional, you're supposed to collect payment.
What page are you on?
I haven't changed one. Tonight, just this one.
Okay.
All right, who says what is fraudulent? Page 18. The Office of Inspector General, the OIG. Each year they develop a work plan, and it outlines the ways in which Medicare program is monitored to identify fraud and abuse. Your MACs monitor those areas that are identified in the plan. Your OIG, again, they are responsible. It becomes a public document. It shows methods and approaches that will be taken in the upcoming year. And it's pretty heavy stuff. It's not bedtime reading. Your complaints of fraud. Who are your complaints of fraud sent to or submitted to? How can they be submitted? Complaints of fraud. You want to submit your complaints of fraud orally or in writing to the MACs or the OIG.
Writing.
You can do it orally or in writing. You can be anonymous.
Do they have like a bulletin or anything for that, for information, if you needed to report that?
Yeah, you can go right on to Google and Google reporting fraud to OIG. So what do you think would be some circumstances that we would report? Give me a circumstance, Darla.
Well, like the phantom billing and all those other, services not furnished, misrepresenting and a diagnosis, all of those. Justifying.
Right. The bottom of page 19 and over on 20, you'll see a whole list of things that could be fraudulent. Completing certificates of medical necessity for patients not personally and professionally known by the provider. Usually allegations can be made by anyone against anyone, and your allegations are followed up by MACs and or the OIG. Abuse generally involves impropriety. It's lack of medical necessity for services are reported. A review would take place after the claim is submitted, and it might go back, and they might even do a historical review of claims. So if they suspect abuse, they might just come into your office and say, give me 20 charts, and I want to see all the claims for these charts or these dates of service. And if they determine fraud and abuse, they can basically close your doors. Kickbacks, I will repeat, kickbacks, bribe or rebate for referring physician or referring patient for any service covered by Medicare. And so if there's any personal gain, it would be considered a kickback. A felony, what would be considered a felony, Angel?
Like if you're embezzling money.
Yep. So you might receive a fine, you might receive jail, or you might receive both. There is such a thing called the Safe Harbor Clause, which protects against certain types of medical services being discounted. Some of the things that might be considered under Safe Harbor Clause would be an HMO contract that with a laboratory, and all the laboratory services receives a discounted price. Those are not protected. Furnishing an item or service for free of charge, that would not be protected. Or reduced charge in exchange for an agreement to buy a different item or service, that would not be protected. So how can you protect yourself? On page 20. Use common sense. Okay? Submit only truthful and accurate claims. And if you're unsure about your charges, check with the physician or the supervisor. Yes. Yes. All right, I'm going to take a quick break and be right back. Get up, stretch.
Drop it.
Okay.
I'm a bad dog. Lay down.
Are we all back, ladies?
I'm back. Can I ask a question? That
Absolutely.
form that you sent us to email Amy, do
Yep.
we just fill out the first part, then initial the rest of the other ones and sign it?
I will go over that at the end of class.
Okay. Stepping ahead.
Okay. All right. So Darla, are you back with us? So on page 20, let's talk about managed healthcare. What is managed healthcare? The purpose of managed healthcare is to provide cost-effective services and improve healthcare services provided to enrollees, ensuring access to care. What year is your page? Okay, so your network healthcare providers that offer healthcare services are usually under one organization, and this is known as your managed healthcare, HMOs. Your group hospitals, physicians, or other providers can be considered HMOs or managed healthcare. Your managed healthcare operations organizations are responsible to an enrolled group or person. They coordinate the various healthcare services and they negotiate with your providers. So your primary care physician more than likely is under the managed care organization and is an HMO provider, and they are called the gatekeepers for your plan. Basically, everything goes through them, and they refer you out to the other specialties. Okay? A PPO, on page 21. A PPO is considered a preferred provider organization, where providers from the network offer healthcare services as a group. The enrollees pay a portion of the cost when they use a PPO provider, and the out-of-pocket costs are usually greater when healthcare is obtained outside the network. And those patients who have an in-plan benefit also have an out-plan benefit. The HMO is a total package healthcare. It allows the enrollee to access all of the healthcare services. Your out-of-pocket expenses are usually minimal. And as I mentioned, you are assigned a primary care physician who acts as your gatekeeper. Some of the drawbacks of managed care, over on page 22. Some of the drawbacks, the organization has incentive to keep the patient within the organization. So your services provided outside are usually limited. Some of the managed care requires your patients basically to just stay within that organization. And if the patient chooses to go outside of the network, a prior approval or an authorization is usually needed. So, you tell me, what is an EPO? Angel, what's an EPO?
It has many of the same features as an HMO, except that the providers of the service are not prepaid.
Right. What is an IPA, Lisa?
I'm not sure.
An IPA is an individual practice association model in which the physician provides services for a set fee. What is a GPM, Emily?
A group practice model, and it's a form of an HMO in which organization of physicians contracts with the HMO to provide services to the enrollee physician.
Yes. A POS is a point of service. The benefits allow enrollees to receive services outside of the HMO healthcare network, but an increased cost in co-payments, in co-insurance, or in a deductible. What is PACE, Angel?
Program for all-inclusive care for the elderly.
Yes. All right, so we're going to take a few minutes. I'm going to let you, let's say, five 5-10 minutes. Oh, actually, we'll just do this and see if we can just answer it all together. We're going to do the chapter review on page 24. So we're going to get a head start on homework so that you don't have so much.
Do we write it in here?
Yes,
Oh.
you can write it right in the book. So, page 24, chapter review. 2 insurance programs were established in 1965 by amendments to the Social Security Act, known as, and what I usually do is I ask each person the answer, and then at the end I confirm whether you are all correct or incorrect. So, Angel, let's start with you. What's the answer?
Part A and Part B.
Okay, Lisa?
Part A and Part B.
Darla?
Part A, Part B.
Emily?
Part A.
Excellent. Part A and Part B. All right, number 2. The secretary of DHHS has delegated responsibility for Medicare to which department? What do you think, Darla?
CMS.
Lisa?
CMS.
Angel?
The CMS.
Emily?
CMS.
CMS it is. All right. Who administers funds for Medicare? Angel.
Patients? I'm not sure.
Emily.
Well, the federal government taxes from.
Right, so what are those taxes?
Social Security.
Lisa?
It's federal.
Darla?
I was going to say Social Security, employers and employees.
Okay. So the answer is who administers funds for Medicare Social Security Administration? Darla, want to turn your volume down just a little?
Yep.
Verb. All right, who is eligible for Medicare? Well, this one is easy, 65 and over, and some disabilities, and permanent kidney failure, requiring dialysis, or transplant. So number 4, 65 and over, some disabilities, permanent kidney failure, requiring dialysis, or transplant. All right, number 5. List the 3 components of the RVU. Darla, what do you have? What do you think?
Did you say Darla?
I did.
Oh, I turned you down too much. The relative values are time, effort, and skill.
Yes. Work overhead and malpractice or practice expense. Okay, what does RVS stand for? Emily? Resource-based relative value scale. All right, and number 7, the fastest growing segment of our population today is what, Angel?
What is the Medicare?
Elderly, yes, Medicare.
Yeah.
Elderly. All right, and then what is the name given to the groups that handle the daily operations of the Medicare program? Lisa?
Is it MAC?
Yes, MACs, Medicare Administrative Contractors. I will give all of you a few minutes, let's say 4 minutes, 5 minutes, to do the matching on page 824.
I can do it.
All right, is everyone finished?
All but
Oh.
one.
That is cute. Right.
All right, let's go ahead and finish up. 9 through 13. Number 9. What do you have for 9, Angel?
C.
D. Emily, what do you have for 10? Okay. D, Lisa?
Excuse me?
10 is D. Sorry, I gave you the answer. 10 is D. All right, 11. What do you have for 11, Lisa?
I have absolutely nothing because I couldn't find it.
Okay. Number 11, you should have I. MSDRG assignment reports are Part A services. 12, Darla.
12 is G, hospital supplies.
Yes, 12 is G. And 13 is J.
We got that
Okay.
one.
13 is J. All right. I'll leave the workbook for you guys to do. Let's talk about the CPC exam sheet that I sent everyone in an email. All right, so the CPC exam worksheet, application. I'm sending it all to you now, and I would like you to print it off. Because when we start getting into week 20, I want to start looking at locations and dates for exams. So this exam application, we will not fill out and send to Amy until around that time frame when we have an idea of when the exams are, okay? But everyone has it. No one can say, I don't know where it is, I couldn't find it on the Evolve website, What are you talking about? Okay. I have a return receipt that it was delivered to your email, so I know you have it. So you're going to fill out the first page. The only section on that first page you're not really going to complete is the payment section. The payment section is for Amy to take care of, because once you complete this application, it gets sent over to Amy, whether by email or fax. You don't have to mail it. And she will set up the exam date based on what you have chosen and put on the application. Now, I believe somewhere in there, I apologize, I don't have my application with me. There is a section that says something about our certificate program for 80 hours, or professional training, something like that. You're going to choose the certificate program of 80 hours. Lisa, do you have yours in front of you?
Yeah, I do.
So can you tell me what area that is?
It's in the middle. It's it's the third section down.
And what does it say exactly?
It says coding course certificate or transcript of completion attached 80 hours or more.
Okay, so that's what you would choose, because Amy will send in the certificate of completion. Okay, and then the second page, you are to read each paragraph and initial by each one. So both pages will need to be sent to Amy. If you run into any questions along the way when it comes time to filling that out, I will be happy to answer them for you.
So we shouldn't show us up.
It's nothing you need to fill out right
We should
now.
just keep it.
I want you to print it off, and I want you to keep it in your binder or your notebook for coding. And I'm going to remind you, remember back on week 6, we were talking about the AAPC application, and I told you to print it off and put it in your binder or your notebook. All right, so I will repeat this again, I'm sure, but chapter 1 probably was a little overwhelming, and it was only chapter 1. You probably felt that the Fordney was overwhelming. As I mentioned at the start of class, you just finished up the billing and reimbursement section. Now we're starting coding. So everything that we're starting right now in coding is the bottom layer of the foundation. You want to take billing, put it on a shelf, and just leave it. Finish up your Evolve exams over the next few weeks. As you notice, they're quick and easy, okay? So you should be able to fly right through them. But now we're into the book, and we're starting to build the foundation. We're starting to build the layers to our coding. First of all, we need to learn about, as we started tonight, reimbursement, compliance, and HIPAA. Then what we're going to address, you will see, we will go next to ICD-9. Then in week 8, we're going to touch upon ICD-10. And I seriously mean touch upon. We will go over a few things, and I will show you what exercise I want you to do using Evolve. But because ICD-10 is not going to be on the national exam, we don't have to worry about it for next year. When we start, basically what we have been told is that you need to learn ICD-10 before you even think about ICD. You have to learn ICD-9 before you even think about learning ICD-10, because ICD-9 is the foundation, the basis for what you're going to learn. So it's not something where you can just jump in and start learning ICD-10. It's not going to happen. All right. So then in week 9, we will learn about the outpatient coding and reporting guidelines. Then in week 10, we will start with the chapter-specific guidelines. And I mean exactly that, chapter-specific guidelines. Then right into week 11, we finish off the chapter-specific guidelines. And in week 12, we talk about your CPT codes and your HCPC codes. So we really will not start getting into a lot of coding stuff until week 13. We will have some coding stuff up to that point, but then we will start really getting into the meat of it on week 13. What I need to stress, and I can't stress this enough, this is not a memorization. There is no way in heck you're going to remember this stuff. All right? We're talking about 14,000 codes. All right? And in ICD-10, they're going to 70,000 codes. Now, I'm sure it's a little bit lower than that, but probably by the time we implement it, it's going to be around 70,000. I think the last time I saw it was like, you're going to from 14,000 codes to 69,000 codes. Okay. The books are still as heavy as the ICD-9 codes. They're a little thicker, and they're more specific than ICD-9. Everything about coding is about coding to the highest level of specificity, the highest level of detail. So if you can keep in mind, this is not about memorization. It's all about learning how to use the tools that we have in this class. So I will be talking about tabbing. I will bring some tabs to class so you can see what it is that I use. Now, honestly, you don't have to tab your books at all if you don't want to. It's personal preference. But I teach tabbing because you need to know how to find the information. And it's so much easier to have tabs in your book, because then you can just flip directly to those pages. I think I showed you, I actually tab my textbook because for me as an instructor, it's just easier for me to be able to go to that chapter quickly. You're going to find the same thing when you're coding. It's going to be that much easier to flip to that section. Okay? So, at some point in time, the light bulb will come on. You will have that aha moment that is like, yes, I get it. Okay? It's just, we're learning the foundation. We have to lay the groundwork to understand how to code what we're going to code. We will run through every body system. We will start off with evaluation and management, which are your exams. So I mentioned earlier that when you go into your primary care, that's considered an exam. It's a consult, it's an exam. Okay? So wherever you go, they're performing an exam as well as the procedures that they are providing. So I want you to make a sticky note or a card or something that says it's not about the memorization, it's about knowing where to find the information. And I want you to be able to go back to that whenever you're feeling totally discouraged, like, what am I gonna do? I can't remember. Okay? It's not about the memorization. It really is not. It's about knowing where to find the information. So for homework, I would like you to finish chapter 1 in the workbook of your step-by-step. Finish up your Evolve exams for the Fordney book, so we can just set that book aside and leave it alone. And then what I would like you to do is read chapter 8 in your textbook. And chapter 8 is an overview of ICD-9. And within each chapter, you have exercises. And I would like you to be able to do the in-chapter exercises as much as possible. And we will end up going over the chapter review answers and the work answers. So you will also do chapter 2 in your chapter 8 in your workbook. Sorry.
So do you want us to do the review at the end of chapter 8 and the exercises that go through
Yes.
the chapter? Okay.
Yes. So for every chapter, you will end up doing the in-chapter exercises and the chapter review and the workbook.
Okay.
And there should be a chapter 1 exam for the Buck book on Evolve, which means I have to go online and set all of you up to have access to Evolve for the Buck book. Remember I said early on there was a reason why I didn't give you access to everything, because I didn't want you to freak out ahead of time. A lot of the coding also will be problem solving. All right, knowing how to figure it out. We do problem solving in our billing job as well. I'll give you, the example I used earlier with the workers' comp, where the work comp insurance only wanted to give 5 visits and the referring provider said 10. Well, knowing what I know about the payers, I knew that we could get into trouble if I didn't get it clarified. Do I have 5 visits or do I have 10 visits? What do you think would happen if we went over those 5 visits and we hadn't clarified anything? What do you think, Angel?
Then you might have a problem with the payment of getting reimbursed for the physician's care.
Right. Exactly. And sometimes it's hard to go back and get things covered retroactively. They can say, well, you didn't do what we expected of you. We told you. You can't feign ignorance. You're supposed to know these things. So anything that comes through my hands that I question, I make a phone call. Because even though I've been in it as long as I've been in it, things change all the time. So you have to be willing to ask those questions. Another incident that happened this week was a patient came in with an Anthem plan. Now, the majority of the Anthem plans say that they can have 36 self-referred visits, and then anything after that, they need a referral. So we had a patient who was over the 36 visits. We told him to go to his primary care physician and get a referral active that day. As long as they got it active that day, we were all set. Sure enough, he called, he got a referral, and I called and confirmed with Anthem. All right, when I originally verified this, you told me 36 visits with a referral afterwards. Is that true? Because the coworker who verified it on the insurance verification form, she circled that there were no referrals required, but off to the side wrote, needed referral after 37th visit. So in that instance, I wanted to make sure not only for my provider that we were going to be reimbursed, but also for the patient. Because you don't want the patient to be caught unaware of that type of a situation and then send them a bill and say, oh, sorry, we, didn't get it covered. So it's a lot of problem solving. What we're doing, what we will be learning is problem solving. Again, don't be afraid to ask questions, to make phone calls. Don't assume we know everything, and don't memorize. It will not be about memorizing. It will be about knowing where to find the information. So, with that, Emily, what's your big takeaway from tonight?
You don't have to memorize everything. Like
Good. And how about you, Darla?
I gotta update my audio system here. No, there's a lot of little subcategories to all of this, but I'm sure I will get it eventually.
Exactly. And how about you, Lisa?
Having to understand all the rules and regulations, how everything's got to be followed, and really you got to dot all your I's and cross all your T's.
Yep. And how about you, Angel?
Just making sure that the insurances, like their pre-authorizations and what you need to do for provide the information and check into it before you assume that it's covered or the patient gets billed instead. I don't want that.
No, and I don't like sending out patient statements, so I make sure verifications are done. And if I have a question on a verification, I actually hand it back to my coworker and I say, do it again. And I tell her why. So, yes, there's a lot involved. All right, so Angel, would you just confirm with Gardner that there is no class next week, please?
Yeah, I already did. None. They're
Okay,
closed
great.
here.
Great. And so we will all be meeting back here on December 4th. All right. Have a great holiday week, everyone.
You
Don't
too.
study too hard or eat too much. Okay?
Thanks.
Bye.
Happy
Thanks for your time tonight.
Happy Thanksgiving.
All right.